Hello, I'm Jean P., and I welcome you to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. I thank you for joining us again today, and we have another great guest and show in store. We're talking about interim health care. I want to introduce you to Jenny Mack, who is an RN and Vice President of Business Development, and Lisa Rainey, who is an RN and Senior Vice President of Operations with Interim Health. So let's talk about who is Interim Health. What does the audience need to know about interim health care and what y'all do for them?
Interim is a locally owned home health company that is in Sandy Springs. It is owned by a father and son.
You're based out of Georgia?
Yes, we are. We are based out of Georgia, but we are a privately owned franchise. There are multiple franchises throughout the United States, but we're a privately owned franchise in Atlanta, Georgia. We cover 7 counties. We provide home health care services to adult and pediatric patients. We provide skilled nursing, physical therapy, occupational therapy, speech therapy, medical social worker, home health aide, and psych nursing, which is one of the things that sets us apart.
Because a lot of home health care companies don't provide that psych nursing?
Absolutely.
Okay, great. Well, I definitely want to talk about that, but there's a bundle in just that first paragraph you said, so let me just dissect that a little bit, okay? First of all, let's talk about the difference between home health care and skilled home health care, because I think in my dealings out in the communities and with patients and families, there's some confusion there. They go to the hospital and they're talked to about home health. Help me explain to the audience the difference between skilled home health and home care.
Skilled home care requires the order of a physician to oversee the patient's treatment at home. A skill can be anything from skilled nursing treatment. One of the main skills that we do is education and assessment. A skill doesn't actually have to be a hands-on like a wound care or a dressing change. Education and assessment is the key to a lot of the things that we do for our clients.
And under skilled home health, the reason you need a doctor's order too is that it's much more clinical in its approach to taking care of someone.
Absolutely.
In the home. It's not just sitting like sitter service or helping with meals or just helping you stay at home upon discharge from the hospital. Is that correct?
Absolutely.
And so how does the billing work for skilled home health care? How about I go to you, Lisa?
Okay. We accept Medicare, Medicare Advantage plans, commercial insurance, self-pay. What we pride ourselves in and what our goal always is when someone comes out of the hospital, our job is to keep them from going back to the hospital. So like Jenny was speaking of, what we do is a lot of education in regards to the disease processes, medications, what you and your family can do to keep you from going back. We spend so much money. Insurance money, tax money with retreating patients for the same conditions over and over because they just do not know how to take care of themselves. You know, one medication can make a big difference. Not knowing how to take that medication can be a big difference. So
I remember that, my grandmother suffered from chronic heart failure. For those folks in the audience listening, that's just something that gets worse over time. And you can live for a very long time with chronic heart failure. So if you have chronic heart failure, I don't want you to worry, but she was in and out of the hospital 5 or 6 times over several months. And when she came home from the hospital, especially that first time, with all of those medications that we had no idea what to do with and when to give them, and we were completely overwhelmed by how to help her stay home and how to make sure she was on her correct medication regime. So I'm assuming that's what your nurse will do. They'll come out and maybe do a book and a log and help get all the family members together in the plan of care.
That's right. Just like you mentioned, heart failure is a condition that you live with. It never goes away. But you can stay out of the hospital if you know how to manage the disease, how to manage the symptoms, how to check your weight first thing in the morning. And if you've gained weight, what do you do? And, I read some research that 80% of the people that return back into the hospital in the first 2 weeks of being discharged is because of medication errors. So them not knowing how the medications interact and even that you check your heart rate before you take it. Lots of things. Our job is to keep you home where you're safe and you're happy and you can be well taken care of.
And what's so important, and I really want to emphasize this, even living it through my grandmother's journey with chronic heart failure, every time someone who's suffering from a disease that is taxing for them on a daily basis. When you go into the hospital because you have an exacerbation, every time she came out, and I mentioned she was in 5 or 6 times over the course of a few months, every time she came out, we had maybe 75-80% of her back. And so for quality of life, but also I think for longevity of life, you want to do everything possible to stay out of that hospital because it's taxing. It takes a lot out of you. And when you're suffering from chronic heart failure and other diseases, you don't bounce back like the regular, healthy person that's not fighting a disease.
You're right. You're right. The nurse can, instruct on how to manage the disease. But then, as Jenny mentioned, we have physical and occupational therapists that can come in alongside the nurse to help with the strengthening, help you gain back as much as you can.
And how do you determine, I'm not sure whether to direct this to you, Lisa, or to you, Jenny, so I'm just going to ask some questions and y'all can tell each other who's best to answer. But how do you determine what staff that patient is going to need when they go home?
A lot of times it's ordered by the physician, but as we see the patient in the hospital or in a rehab setting, we evaluate them to see what their needs are, to see what their baseline is prior to discharge. So we go ahead and we look at them as a whole. We look at where they're going, who they're going to return home with, and what services they would need to improve their quality of care, and to also get them back to their baseline.
And the goal for home health, for skilled home health, is to improve your quality of living when you get home. Okay, because you've mentioned so many staff members. You have a doctor who writes an order who oversees your team. You have a nurse that will come out and help them with medication and teaching and the clinical needs for the physical illness. You said you had social services?
We do. We have a medical social worker.
A medical social worker. Who am I missing? Because you spewed off a whole lot of folks. And then you've got therapy team, physical and occupational.
And speech.
You do have speech. Okay.
And home health aid.
Oh, and a home health aide. And how often can folks expect to see these people?
Our care is intermittent care, so we usually go 2 to 3 times a week. For a patient to qualify for home care, they have to be at a baseline to be seen just 2 to 3 times a week. If they require more than that, it's best for them to go into a rehab facility.
Right, and that's important, folks, because you still have to be able to go home from the hospital. You still need family or support or someone to help you when the home health team is not there visiting and monitoring on you and reteaching you and helping you stay on track. They're not going to be taking care of you 24/7. That's intermittent care only. If you need 24/7 help, you probably have to transition to some kind of a facility before you can go home and get the home health when you're leaving the facility. Is that correct?
That is correct.
Okay.
Absolutely.
This is great information, ladies, because it's so overwhelming for folks who are in the hospital and trying to decide what the best discharge plan is, and nobody wants to go to a facility. But sometimes that is the best case if you need a little bit more time to energize yourself and to get back maybe from that 60% of yourself to 75% of yourself before you hit the home health.
You're right. You have to think when you're leaving the hospital, you want to go home, just like you said, no one wants to go to a facility, but can I go home and can I do it safely? Can I take care of myself? It's very hard for us when we get to a home and there's such high expectations because home health maybe wasn't properly explained in the hospital. So you get there and this person is almost confined to their bed with no family. So how are you going to get to the bathroom? How are you going to fix your meals? How are you going to take care of yourself? If you fall, who's going to help you? We're not that kind of agency, and it's hard for us once you get home to make that right for you. Because to get you back in the hospital or into a facility once you're home is just extremely difficult.
That's a great point, and it gets my mind moving, too, that there might be an instance where if you're adamant about going home, you can still go home and not go to a facility, correct? But that's when you bring in, and to help people not stay confused, the home care agencies to accent the skilled home health care that they're getting in the home that's intermittent. So Jenny, do you want to talk about how the two of your agencies can work together to help people stay at home as an alternative to going to a facility?
Absolutely. We go ahead and we talk to the patients prior to discharge about who's going to be home with them. So then if no one is going to be home with them, we give them options about agencies to contact that can provide, we call it activities of daily living, ADLs. So that is bathing, dressing, toileting, meals, laundry, cleaning, and transportation. And those agencies come in and work side by side with us. We do more of the medical and the clinical, and they do more of the activities of daily living.
You're helping them manage their disease so they can live at home with their disease. They're helping them manage their life.
Correct.
And living in their home while they're trying to get better from the disease.
Yes.
I got it. Okay, great. And those kinds of agencies, though, those are typically private pay. So that would be an additional cost. But if you're adamant about getting home, that might be something that you would want to investigate.
Absolutely.
Wonderful information, folks. And now we're going to just take a quick break. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. We're talking to Jenny and Lisa here from Interim Healthcare, and we've had so many great discussions about what home health is and how it can work in conjunction with home care. But let's talk about the reimbursement. So if I could just bring y'all back for a minute and talk about the fact that the skilled home health is paid for by Medicare or Medicaid or private insurance. Is that correct?
That's correct.
Okay. And is that at 100%, or do they sometimes have to pay some out of pocket?
Sometimes when they have a private insurance, they might have a copay. So that is something we investigate when we do the certification of the patient. So we know if they have a copay, so we can tell them out front, because they could be on a fixed income. Money doesn't grow on trees, and we like to educate our patients on what their care may cost them.
And that's just for private insurance, because a lot of folks will have the Medicare benefit if they're over 65 or on disability, correct? So, and in that case, does Medicare pay at 100%?
Yes, it does.
Okay, so that's good to know. So just to remind y'all, if you're getting skilled home health to help you discharge from the hospital back into the home, and you have Medicare or Medicaid here in Georgia or other states, it is paid for at 100%. Some private insurances also pay for skilled home health, but there might be some costs in addition. Don't fear, because with Interim, they're going to make sure there's clarity up front and you make your decision based upon what that cost is going to be. Now, just to remind you and bring you back to what we were talking about in the beginning of the show, it's intermittent care. These folks are not going to be there 24/7. And if you don't want to transition to a facility before you go back home and you're adamant about going home, you may need to purchase some additional care called home care, which is not skilled and not paid for by Medicare or Medicaid. However, I think I'm going to direct this one to you, Lisa. Is this paid for by some insurance, and how does that work?
Absolutely. If you happen to have a long-term insurance plan, there are a lot of these plans that have coverage for the private duty. So there's a lot of different ways they'll talk about this person that you're looking to hire. It could be home care, as you refer to it. It could be private duty.
Yeah, they call it
homemaker
private
services.
duty, homemaker,
Absolutely.
sitter services, or
All of
home
that.
care. So what you want to check out is skilled home health is typically the one that's paid for by the government. And then the home care is the additional services that will be in there longer.
Yes,
to
and a
help
lot
you.
of people do not realize that within their insurance plans, some commercial even have some benefits for the private pay, the homemaker services, and then the long-term insurances. And it could be 40 hours a week that is covered by your insurance. So you really need to know what your insurance plan has.
And that would be the long-term care insurance. And also, because I've interviewed some folks in the past, if you're a veteran or a spouse of a veteran, you may benefit from some additional monies paid to you for home care as well. So you should look into those programs as well.
Absolutely.
So a lot that you have to do while you're in the hospital if you're stricken with an illness. So don't wait. That's the whole point of Better Living. We bring this show to you in order to educate and inform you about all aspects of living so that you're prepared before the crisis hits. like everything, much better if you know what you're going into should something happen to you. So we talked about who Interim is, but I'd like to know, where is Interim? You mentioned that you're a franchise type company and y'all work in Sandy Springs, Georgia. We also air our show in Phoenix, Arizona, and New Orleans, and the Gulf South. Is Interim in those markets as well?
We have 300 offices across the United States.
And how about if you give a website and a phone number if people had questions about your company, who they could call to find out where the nearest office is near them?
Sure, interimhealthcare.com.
And is there a 800 number or a local phone number here in Georgia, and they can just kind of direct them to
There's
whatever
a local
else?
phone number. You can dial 404-856-6100.
And is it interimhealthcare.com?
interimhealthcare.com.
Terrific. So, folks, if you or a loved one or a neighbor or anyone you know is struggling to stay in the home, there's another question for you. Do you have to go into the hospital in order to qualify to get home care? Or could you just be at home declining and get it?
That's a very good point that I wanted to bring up. You do not have to be in the hospital to be eligible for home health care or skilled home health. You can be living at home, you can be in an independent living community, an assisted living community, and still be eligible. Again, our goal is to keep you out of the hospital. So if you go to the doctor and he identifies, oh, your blood pressure's up, my gosh, we need to get some monitoring for this, or your blood sugar's out of control, or the heart failure symptoms have come back at a doctor's appointment, or even your daughter or your son or your husband or wife notice that you're declining, absolutely. The first phone call is to the doctor. Try to get in to see your doctor so that he can see what's going on, and the doctor will call us directly and get home care started. And it doesn't always mean that you need a nurse. A lot of times our referrals are just for therapy, that people are very up on their diseases, they've educated themselves, but something's happened and they've gotten weaker. Maybe you've had to have a knee replacement, a hip replacement. Not that you've fallen and hurt yourself, but just with age, deterioration. A lot of our patients are physical therapy only patients, and that's fine too.
And that's a very good point, because like we talked about before, and I can only speak from personal experience, but keep yourself out of the hospital, keep yourself as strong as possible, and you're going to have a better quality of life and longevity of life. So don't wait till you get so bad that you need a hospital stay. If you find yourself struggling more and more and more to stay in the home, call Interim, or go on their website, make a call and inquire. If you find yourself calling your doctor's office a lot more or going to visit your doctor a lot more, they may not know the full picture of what's happening to you while you're in the home. Advocate for yourself and call these folks in. They're not going to take over for your doctor. They're going to work in conjunction with your doctor to keep you home. Is everything. We have to advocate for ourselves. And that's important. They keep their own doctor, correct? If they have skilled home health, and then they have another doctor that oversees your team, or?
Their doctor oversees our team. We do not do one thing unless we have it okayed through their doctor. So we don't do anything. We don't make any decisions, really. Okay. We go in, we do an assessment, we call the doctor from the home and say, this is how we found your client. This is what we're thinking we can do to help meet the needs and the goals you've identified. And he will either say, or he or she will either say, yes, that's a good treatment plan, or no, this is the way I want to do it. We work solely up under the orders of a physician.
So that's another benefit, because if you're out there and you're seeing folks in the home, you have a connection to your doctor. The nurse will come out, if you have a nurse, or even the physical therapist might understand that there might be a need of a change of a medicine or something. And then what if they're not getting nursing, but they're only getting therapy? Do they just call your office and say, I think these folks might need a change in med? How does that work?
Our physical therapists obviously are very well trained and very professional, so they are always checking blood pressures, heart rate, lung sounds, and they're very familiar with their patients. So if they go and see that the patient has changed or the client has changed from the previous visit, they don't wait till the next one to make sure they're better. They get on the phone and say, I feel like something's going on here with your client. Either we can get them in, or if you don't have an appointment, you want us to get a nurse out here and do another assessment and see what's going on.
Okay, great. I think we've talked a lot about how you're not continuous care and you're intermittent care, but let's talk about what can someone expect. Let's walk them through the discharge from the hospital and getting back in the home. How do you help them? Because I think those first 24, 48 hours are most important.
What we do is we go ahead and we receive a call from a discharge planner, and at that point, we take initiative to go ahead and meet with the patient. After we meet with the patient, we have a physician's order. We sit down and talk to them about their discharge disposition. We talk to them about.
I think my discharge disposition might not be very good. If I'm in the hospital, I may be kind of cranky. I'm only kidding. I'm sorry.
We identify where you live and go ahead and go through all the demographics of everything. And then we tell them when we'll be out. We'll usually come within 24 hours to go ahead and get their care started. We my staff call the patients the next day to assure that their nurse or therapist has been to the home. And then from there, we do a plan of treatment and call the physician. They also receive our card from our staff that has interviewed them and set up their care. So they always have an additional point of contact beyond the office.
I see. Okay, so they're in good hands. They're transitioned home. They're taught about their medications. They're given tools to monitor, and so that the whole family, if they're helping with the care, can see the log of when they got their medications and work together in the care of that loved one. And they have the equipment and needs taken care of so that we can get them on the road to living independently again. Well, Jenny and Lisa, thank you so much for coming. And again, folks, if you want information about home health, you can go to the website at www.interimhealthcare.com, or you can call our local Georgia office here and they'll connect you to your appropriate office. And that number is 404-856-6100. Ladies, thank you so much for coming. Important information to get out to the folks in our communities.
Thank you.
I'm Jeannie Pete with Better Living. Again, we're sponsored by the Homestead Hope Foundation and brought to you by Homestead Hospice. And you can reach us anytime about any one of the guests that we've brought to you, and we can connect you to all of our resources. And that number is 678-966-0077. Until next time, have a wonderful week. Hello, I'm Jean Pete, and I welcome you to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. I thank you for joining us again today, and we have another great guest and show in store. We're talking about interim health care. I want to introduce you to Jenny Mack, who is an RN and Vice President of Business Development, and Lisa Rainey, who is an RN and Senior Vice President of Operations with Interim Health. So we've talked a lot about the different types of home health and home care. Let's talk about what are the top 3 diagnoses that y'all see in your skilled home health care?
The top 3 diagnoses are congestive heart failure, diabetes, and COPD.
And we talked a little bit about what the nurse can do and what the physical therapist can do. We've talked a little bit about chronic heart failure as well. But let's continue to walk folks through. We talked about the transition from the hospital, how you helped them get in the home and did some education. Now, is the equipment there? Let's just say someone with chronic heart failure is coming out of the hospital. They've chosen interim skilled home health. You've signed all of the paperwork. You've done the evaluation. When they get home, is a nurse there to meet them, or do they get home and get situated and then you come within a day or two? How does that work?
They get home, get situated, and we usually come the next day.
Next day. Mm-hmm. Okay. So it's good to have a family member stay with you that first day out of the hospital.
Absolutely.
And to make sure. And they can call you if something occurs prior to that next day occurring, because you still want to keep them out of the hospital. Is that correct?
Absolutely. We're just a phone call away.
Okay. So if you needed to send someone out, are you 24/7? Could someone go in the middle of the night if needed?
Yes.
Okay.
And 7 days a week.
This is all very good information, because it may take a day for the team to get started, but don't wait if you need it. Don't go calling 911 and going back to the emergency room and going back to the hospital, because perhaps they could send someone to you and get you started a little early, and you just wait for the equipment the next day, right?
Usually the equipment gets out sooner. Upon discharge, the equipment is ordered for the patient and arrives at the home that day or is sent home with the client. The equipment is something they never have to wait on. Usually, according to Medicare guidelines, we have to go ahead and start the next day, unless it's a patient that requires something like an IV infusion or tube feeding, or a brittle diabetic that has problems with their vision that cannot administer it independently. We go ahead and go out there. So we kind of assess them to see if they qualify for a same-day start.
I see. Okay, so it's really based individually on the needs of the patient.
Yes.
Well, that's terrific. So going back to chronic heart failure, because I want people to be able to visualize the kind of care that they're going to get and the kind of support that they're going to get so that they can say in their own minds, I can do this. I can go from the hospital. I can go home. This is what my family needs to do, and this is who's going to be coming to help me. So they get discharged from the hospital. They go home. The equipment's there. If they need a special bed, if they need oxygen, do you all take care of oxygen?
Yes, we do. We go ahead and set that up.
Okay. And they have chronic heart failure, and they get settled in the home. Next day comes. Who typically visits first?
What happens is a registered nurse will call them and make an appointment to come to their home. They go ahead and set up the visit time, and the nurse comes out and does her assessment. We go ahead and go over all the medications that they have in the home and then assess them what they're going to need. We do a full head-to-toe assessment. For example, the CHF patient, heart failure patient, we go ahead and we will bring a scale to their home so they can start managing their weight right away, so they know exactly what their weight is the day that they got home. And from discharge, we will have documentation of what their weight was when they left the hospital, so we have a great baseline to give to that physician and for our nurses to follow.
And for the folks with chronic heart failure, it's so important to monitor weight because the salt intake and the little bit extra pounds, I remember when taking care of my grandmother, that can throw you all off and be the start of a decline, correct?
Absolutely.
So it's important to take that weight every day. So do you have those folks take that weight and just call you, or they log it in a journal for your next nurse's visit, or how does
We
that work?
usually have them have a log and they document their weight. A lot of times they'll have parameters set by their physician. If they have a 3 to 5 pound weight gain overnight or within a 48-hour period and our nurse has not made a visit, they can go ahead and call our office, and then we will call the physician and let him know that their patient has had a change of status.
And that's another reason why it's so wonderful to have home health with you, because if you are seeing the weight gain and maybe you are behaving and you're not eating poorly, they might just mean that you need a change in your medication dosage. And we can catch that if we have home health in there with you. It's not going to require another exacerbation. You're going to catch it before something happens. Okay, terrific.
And what I'd like to say, Jeannie, is you keep using the word transition, and that's a great word, and that's something that I feel that Intrum does such a great job with, is transitioning someone from the hospital to home. Jeannie and her team make sure the transition is smooth, that the hospital bed, that the oxygen is there before they get there. Or they're going to be in a mess. If they need oxygen and they have to wait 24 hours,
Right.
maybe they can't wait 24 hours. I mean, they would not survive.
And that's not something they have to pay for themselves, because that would be covered with the skilled home health benefit.
That's right. So a representative from our agency goes and visits, the client in the hospital once they get an order from the doctor. They make sure that all the equipment is ordered before they get home. They make sure that the client has the medications, and if not, they get with a doctor and say, we need these prescriptions. If you're a heart failure patient and you need something to help you breathe, you can't wait 24 hours once you get home to get that prescription called into your pharmacy.
No.
You need it when you get home. So that sets us apart at Intrum Healthcare. We understand transition, and to make it a successful, efficient transition so that you stay home, we do a lot of work on the front end before you get there. We want you to stay home. When I interview prospective employees, when I'm interviewing a possible new nurse or a therapist, part of the interview is the goal here. When we hire you, the goal is to keep these clients home. So are you strong in education? Are you strong in a skill set? Because even though you may be a wonderful nurse, if those are not your strong skill sets, this may not be the place for you, because we need strong education once they get home. We want to keep you home.
Terrific. Thank you for clarifying that. Okay, and then how long do you follow these folks? How do you know when it's time not to be with them anymore?
Everybody's different as long as it takes. It may be for someone who's went into the hospital for a total knee, total hip replacement. We may have them for 2 weeks. Someone with heart failure, we may have for 3 months. If it takes us 3 months to teach that client and their family how to properly take care of that heart failure client, then it takes us 3 months. Not everyone, once you come home, a lot of people are so anxious and overwhelmed. We try to come in and teach everything, but you cannot absorb all that. Some people can, some people cannot. But for people who have chronic diseases, and maybe just not one, maybe you're heart failure, diabetic, and a COPD, and high blood pressure, it may take us 3 months
I see.
to get you where you have a clear understanding of how to manage all of those diseases. I mean, some of these clients are 70, 80, 90 years old, and it just takes a little bit for all of that to be absorbed. What we want to do, because in a couple of years, I mean, hospitals will be fined. Doctors will be fined if their clients go back into the hospitals. So it may take us a little more time for some people. Some people maybe 2 weeks, some people 3 months.
And that's a whole nother show we should do, is the changes in the way the healthcare system, it looks like the healthcare system is going, because these hospitals are getting it. They need to get them out, and they need to keep them out.
That's
so
right.
Because now financially they're going to get hit too. So you're going to see a growing trend for pushing to nursing facilities or pushing to skilled home health.
Mm-hmm.
And so, folks, the more you know, the more you understand your choices and how it all works, and the more phone calls you make and websites you look at. Keep listening to Better Living, sponsored by Homestead Hospice, but be your own advocate and understand what your choices are, because you do have choices, and it's not going to be what's easiest for the hospital. Let's get them out quick. It's what's best for you. So that's great that you walked us through that transition point. And thank you for talking about chronic heart failure, because we know that's near and dear to my heart. I have another question. It's going to make me look a little silly. But let's say I happen to know someone who had an elective surgery. Would that qualify for skilled home health as well, because they didn't go to the hospital and have a surgery? But this person had a really hard time recovering. Even though it was their choice and it was elective. Could they just call skilled home health?
That's a good question. Maybe we should clarify the different ways that we can treat patients. The Medicare Advantage population are 65 and older. In order for skilled home health to be paid for, you have to meet 3 criteria. Number 1, you have to be considered homebound, which means it takes a taxing effort to leave the home. Now, we don't want you to stay homebound. Our goal is always to keep you out of the hospital and get you back to your prior level of functioning. So you have to be homebound. There has to be a need for us to be out there. And then thirdly, and most importantly, we have to have a doctor's order to do so. With the commercial insurance plans, sometimes you do not have to be homebound in order to get the benefits. So as you are talking about an elective surgery and they're not doing well, are they homebound? What is their payer source? Is it a Medicare patient, or is it a commercial insurance? If they have a commercial insurance, does the benefit say that to receive skilled home health that you have to be homebound?
I see. And that's a good thing to note, because, okay, let's talk. Elective surgeries are on the increase right now, right? I mean, we could be talking about all kinds of stuff. Let's just say somebody had a
Cosmetic surgery.
I think a lot of them are homebound, at least for those first few days. Is that too short of a time for skilled home health to come in?
Absolutely
so
not.
There's no length of stay that they have to meet.
It could be a one-time visit only.
We always tell patients, to me, a great qualifier for home care is a change of status. Homebound with a change of status, that could be anything. A fall, a new medication, a blood pressure change.
Yeah, because I know someone who came home after having cosmetic surgery and had an infection.
Absolutely.
And they really weren't in very good shape, and you got to get on top of that. And to get them out and get them to the doctor was very taxing, just to have that wound looked at. So wonderful information, folks. And now we're going to just take a quick break. Hello, I'm Jean Pete, and I welcome you back to our show, Better Living. Better Living is brought to you by the Homestead Hope Foundation and is sponsored by Homestead Hospice, where commitment to education and premier hospice care helps patients and families through life's most important journey. So we've talked a lot about the different diseases. I do want to touch on diabetes, but I also want to talk about, a lot of times folks end up in the hospital because they had an accident, fell off a ladder, got in a car accident, or something else occurred, had an infection, went in and had to have emergency surgery, and now they're suffering from some wounds. So let's start with diabetes. How do you help folks who have diabetes regarding your skilled home health? What are the different staff members that might come into the home, and what might they do for those folks?
It could really be the exact same staff members as those who treated our heart failure patients. I mean, a nurse is going to go in, we're going to assess the patient, we're going to make sure they have the supplies, that they have the glucometer, the strips, the supplies needed just to monitor their blood sugars. We're going to make sure the medications are in the home. If they need insulin, that the syringes are in the home. We're going to make sure they have all the equipment. And then we're going to teach them. We're going to teach them how to monitor their blood sugar, what's low ranges, what's high ranges, what do you do if it's low, what do you do if it's high, when do you call the doctor, what you can do to manage this. It's very important that they know their diet, their exercise regimen, and that you stay consistent, that you keep up with your blood sugars. And it also could be that they've had an extended stay at the hospital because of their blood sugar. It got so high that they had to go in and they were there for days. So when they came out, they were just so weak. It's crazy how 2 days in a hospital, you lose 50% of strength and energy. So they may very well need the physical therapist to help regain their strength. And in the meantime, they may need the home health aide, which is the girls that we send in to help with the bathing. In the meantime, when just taking a shower wears you out and makes you unsafe. So we have those people that can come in, and those people can come in for as long as they need to be there until those people are able to return to their prior level of functioning.
That's great. Let me ask you this, because I have some friends who have diabetes, and I think their biggest problem is that they're so not compliant with what they know they need to do. Mm-hmm. So you're in there and you're monitoring them, and you're making sure they're staying on top of their medications, and are you sending a nutritionist or a dietitian in there too, or is that outside of your scope?
We do not have a nutritionist or dietitian, but we have.
But those nurses are going to be on top.
They're trained in that, absolutely. And
the physical therapist.
That's right. Even for diabetes and heart failure, we have excellent. It's almost like clinical pathways. Booklets, education booklets that we have prepared, that we leave in the home, that we teach from, but then we leave for you to read and reread and memorize. And they're so good. My mother was recently diagnosed as a diabetic. I took her that book from our agency because it's very simple, but it makes perfect sense. Being compliant's the hardest part. Mm-hmm. It's very difficult. It's real easy for a nurse to say, you should do this, you should do this, you should do this, but you're not that person suffering, and ever so often you fall off the wagon and you do something that you shouldn't.
But that's another great, the nurse is going to be there, the nurse is going to be talking to you and monitoring you and showing you the effects of what you're eating and what you're doing, and if you're doing exercises and what have you, from the physical therapist as well. But the whole family really needs to get involved, and that's the beauty of having someone come into the home so that they can talk to the family. Because, I'm going to say it again, I've talked about this on several shows, but I recently lost 70 pounds. And if the whole family is involved, you're going to be more compliant. And then your sister, your daughter, your spouse, your son, they're all on board. All of a sudden, things start getting cooked that are healthier for you. And so a lot of this, too, they need to take into their own hands. I'm going to get off my soapbox now. But with diabetes, it's manageable if you can live a much better quality of life and recuperate from your hospitalization a lot better if we can just get you on track.
That's
and there's
right.
so many resources for that.
There is.
Do you have anything on your website maybe helping folks with diabetes, resources or website connections?
We do not, but if anyone was ever interested in looking at some of our resources, if they would call our number, the 404-856-6100.
Or they could call that 800 number for the whole country, no matter where they are, and that's 800-338-7786. And they can direct you. But I also do want to remind you, this is Better Living. It's sponsored by the Homestead Hope Foundation and brought to you by Homestead Hospice. And we connect with all of the guests that we have on our shows. And we have had past shows with folks from the Diabetes Association. And I know that we've got access to websites regarding healthy eating, and we've had exercise physiologists on the show. So lots of great information, even if you want to just come to our website and get connected to all our past guests as well. And that's homesteadhospice.net. Well, now we talked about the diseases. I want to talk about accidents and when folks end up in the hospital because, like I said, they fell off a ladder, or how does that differ from treating a disease?
Basically, after we assess the patient status post-accident, we see what their needs are and what their baseline is. Usually, if they've had an accident, they've either been in a facility or a rehab. And at that time, we assess what their baseline is and what we think they'll need. Usually, we would probably send in a skilled nurse, physical therapy, and occupational therapy. But it also depends the patient's baseline, family support. And one thing that I wanted to reiterate, too, is one thing that interim healthcare does is our goal is to make the patient and family and have them have ownership of their diagnosis, and then they're more intrigued in learning about their diagnosis, because as you said earlier in the show, be an advocate for yourself. Well, we all have to be an advocate, and also take ownership of ourselves and the diagnoses that we have so that we can proceed forward and have a great life and still live the journey we want to.
Don't give up, because those nurses and those physical therapists are going to be out there pushing you to get better. All right, terrific. Now let's talk about wounds, because that's a biggie. You get out from surgery and you don't do, and I'm not saying I know this from experience, but you don't sit long enough and you don't do what you're supposed to do and you end up reopening your wound. What do y'all do for people who have wounds?
The nurse will go out, status post-discharge, or even if they're from a physician's office. We have some patients that will show up at the physician's office and may have skin breakdown on their bottom or on their arm. We go out and assess that client, and then we usually set up a wound protocol and call it in to the physician after assessment, and he okays it. A lot of times the physician may send a wound protocol for the patient, but we will address the patient, look at everything, and decide how we feel we should proceed with that, and then contact him.
So it may be different than what the initial thought is after you get out there and you see it and you're working with them.
Right. Well, and also with wounds, you have to think of other disciplines that play into it. For example, home physical therapy. Are they laying on their back too often, and that's why they have a wound on their bottom? Do they have diabetic foot ulcers? And maybe that's something we had to work on, is mobility and transfers. The nurse has to look at nutrition. What type of nutrition do they have? Do they have a high-protein diet to help the wounds heal? And also, maybe they have renal failure. So then if you have a high-protein diet and renal failure, you have to look at both those issues.
I see. And nutrition is so important to the way the whole body works. So, you know, back to being an advocate for yourself, the better you behave those first few weeks out of the hospital, the better off you're going to be. Well, wonderful. I do want to just kind of backtrack and give a summary before we have to end. We never have enough time here. But if you or a loved one, someone that you know, is in the hospital, has had an accident, has a disease, they might not have been in the hospital, they're just declining, they're having a harder time getting out of the house, you're worried about your neighbor, what have you, do call Interim Home Healthcare and see if they can help you and assess that loved one or that neighbor to see if they can get care while they're in the home, and we can prevent them from even going to the hospital. Again, that 800 number is 800-338-7786. To qualify for skilled home health care, which is covered by Medicare, Medicaid, and some private insurances, 3 things have to happen. You have to be homebound, which doesn't mean you can't ever leave the house and go to church or go to the hairdresser or what have you. It's just a taxing effort to leave the home. It isn't easy for you to get in the car and to get out. And there has to be a need that's identified. You're suffering from some kind of a disease, you have a wound that's not looking very good, you had an accident, hip replacement, what have you, and you need help getting yourself better and increasing your quality of life. And we do need a doctor's order, but don't let that hold you up, because they can come out and talk to you and call the doctor right there from your house and see if they can get the order while they're there. They can talk to you. No one can touch you without a doctor's order, but they can always educate you on what services would be available. So don't wait. Be an advocate for yourself. Get ready before the crisis occurs, and contact help today, because that's the whole point of Better Living and coming out to you all each week. I'm blessed to be your host, Jeannie Pete, and I hope you all have a wonderful week.